Thank you all for joining us. We're really happy that you've joined us today for this webinar on CAT-1004 and the MoveDMD trial. The positive results from Part A of the MoveDMD trial and the design and inclusion criteria of Part B, or Phase 2 of that trial, is what will be reviewed today. Our speaker is Dr. Joanne Donovan. So Joanne is the Chief Medical Officer of Catabasis Pharmaceuticals. She received her academic training at MIT, Harvard, and the Brigham and Women's Hospital in Boston, and has many years, more than 15, of drug development experience, taking programs from Phase 1 to approval. She still remains currently an Associate Clinical Professor of Medicine at Harvard and continues to practice medicine and teach. We're thrilled to have her. This is Pat Furlong from PPMD. I will be guiding the webinar and asking Dr. Donovan questions. And the first one I'm going to start with before she takes over is to ask her to help us pronounce the name of this drug, because I struggle with it continuously. So with that, I'll turn the meeting over to Dr. Donovan and ask her to begin with the pronunciation and go from there. Thank you.
Thank you very much. And Pat, we're very pleased to be able to share this information with the Duchenne community. I realize, as you point out, the pronunciation is not going to be is not quite easy. We didn't ask for quite as many syllables. We are pronouncing it Edasalonexent. So with the accent on the first syllable and the next syllable. So Edasalonexent.
Edasalonexent. Thank you. That's very helpful to all of us.
I probably will call it CAT-1004, as will many of you, for a long time. So I am delighted to talk with you all about where we are in the clinical program. We had the opportunity to share our information last year, about a year ago, and since then we've made a tremendous amount of progress and are now in the midst of the Phase 2 part of the study. Actually, the arrows. So first I will just show the legal slide, which will remain on there, and of course my conflict is that I am an employee of Catabasis. So Edasalonexent, we believe, is potentially a disease-modifying oral therapy for Duchenne. It is potentially an agent that could be used across age groups and across genetic mutations. So it is not a genetic mutation-specific therapy. It's an oral drug. The capsules are shown there on the left-hand side, and it is targeting what we believe is a central pathway in the pathophysiology of Duchenne muscular dystrophy. It's called NF-kappa B, and I will tell you a little bit more about why we think that that's important and why we're targeting that with Edasalonexent. In some of the preclinical studies done in animals, we have shown that there is effects not just on skeletal muscle, but also on respiratory muscle as well as cardiac muscle that encourages us going forward. And in the Phase 1 studies, we were able to not only look at things like how much of the drug is absorbed and the safety, but we were also able to show that we were able to target this protein, NF-kappa B. We showed that in adults, and now in Part A of this study in younger boys 4 to 7 with Duchenne, we were able to show that we had effects after 1 week of treatment on this protein, NF-kappa B. So right now, we are in the midst of the Phase 2 study, and we're actively enrolling that. So why are we going forward with Edasalonexent? And as many of you know, in Duchenne, of course, the lack of dystrophin is universal, but dystrophin is actually a shock absorber protein. So the lack of dystrophin, along with mechanical stress, is known to activate NF-kappa B. And it's that activation, that active protein in NF-kappa B in muscles, that ultimately there's a lot of information that shows that that leads to muscle degeneration, to inflammation in the muscle, and ultimately to fibrosis and inhibition of muscle regeneration. And the net result is loss of function in the muscle. We know that steroids suppress inflammation and, in fact, do target NF-kappa B, but as you all also well know, steroids have significant side effects. So how does NF-kappa B do this? So when this is a protein complex, it's present in muscle, present in all cells, and in the absence of dystrophin, along with mechanical stress that occurs in muscle to a lesser or greater degree throughout the body, but it's these two things that activate NF-kappa B, and that leads to multiple effects on the muscles. In the center, the activated NF-kappa B leads to inflammation, and it leads to the production of many different proteins, which also ultimately lead to fibrosis in the muscle. Steroids are actually very good at this effect, at suppressing inflammation. There are also other effects, though, that come along with activation of NF-kappa B. One of the most important is inhibition of muscle regeneration, so that the inflammation not only causes the inflammation and fibrosis, but it prevents the muscle stem cells that are there in all muscles from regenerating and repopulating the muscle. We know that steroids, in fact, are a net negative. In other diseases, steroids have negative effects. In Duchenne, the net effect is positive, but we also know that steroids do have these negative effects on muscle regeneration. The activation of NF-kappa B also triggers regeneration, triggers decrease in protein synthesis and an increase in protein degradation in the muscle. And the example of the muscle that I've shown here is actually a magnetic resonance image of the muscle, and I'll talk more about that because that's very much involved in the design and the conduct of the study. There's a lot of information from studies over the last 10-15 years that if you're able to target NF-kappa B, then it produces disease-modifying effects in animal models of Duchenne. Eric Hoffman was the first to show that NF-kappa B is chronically activated in Duchenne due to the lack of dystrophin, and you see this very early. Actually see it in infancy before the muscles look very different or are impaired in terms of their function. In the animals, the MDX model is used most often. We know that if you reduce NF-kappa B by 50% by knocking out one of the genes, that itself reduces muscle degeneration, enhances muscle regeneration, and improves muscle mass and function. And there are also other models using pharmacological ways of affecting NF-kappa B that show that this is an important pathway. On the left is shown a stem cell implantation in an MDX animal, and there the red shows the dystrophin produced in these muscles, and that's in a normal, in an MDX muscle with intact NF-kappa B level. If you reduce NF-kappa B by 50%, then you can see there's quite a bit more dystrophin produced there. So we think there's many lines of evidence that that inhibiting NF-kappa B can have a beneficial effect on dystrophin production and potentially even be used in combination with dystrophin-targeted therapies, but that's very far down the road. So we're developing this in Duchenne for these reasons. Now, it's not just the absence of dystrophin that plays a role in Duchenne. This is a cross-section of the thigh muscle in a boy who is unaffected by Duchenne, about 14 years of age, and a boy with Duchenne. And in the unaffected muscle, it is dark, it's homogeneous, but with Duchenne, there is the replacement of the muscle with fat and fibrosis. And what is notable is there's a couple muscles here that are more involved in twisting muscles, the gracilis and the sartorius muscle. And those muscles that have less mechanical stress seem to be relatively protected. So it leads us to believe that if we can decrease NF-kappa B, we can protect the muscles and have an important effect on the disease. So we've shown in preclinical studies that Edasalonexent inhibits NF-kappa B and has all of these effects on muscle degeneration, inflammation, and fibrosis. And as I'll show you on the next slide, we have effects in multiple muscles, and we have shown that the Edasalonexent is relatively concentrated in the muscle. So we've done these studies with Professor Lee Sweeney at University of Florida, formerly at Penn, with both Edasalonexent and a closely related analog. And with those, we showed in MDX mice that treated for 6 months that both Edasalonexent as well as the analog improved muscle strength after repeated contractions. The animals are on a running wheel, and we were able to show that the analog increased muscle endurance, and it also improved diaphragm muscle in these animals. And when we looked at these under the microscope, we could see that there was a decrease in fibrosis. Fibrosis is the blue in the untreated animals versus the treated. And there was an increase in the muscle mass, the gastronemics, in the lower leg and the quadriceps shown in the green here, versus the control animals, the untreated animals. And we were actually able to see a small decrease in the cardiac size. And these animals are at the age where they start to have the development of cardiomyopathy. So a decrease in cardiac size is actually beneficial, potentially. They're beneficial in the animals. So we've taken the drug, Edasalonexent. First we did phase 1 studies in adults, and this is the first step in drug development to see how the drug is metabolized in adults and whether it's safe. And we did this initially in 3 phase 1 studies prior to starting the current study in boys with Duchenne. So we looked at a single dose, we looked at multiple doses over 2 weeks, and we also did a biomarker study to specifically look at NF-kappa B. 79 adults. We did not see safety signals. It was well tolerated. And we were able to see that the genes that are targeted by NF-kappa B were reduced in activity after 2 weeks of dosing in the adults. The Edasalonexent is actually a molecule that is a conjugate. It's a molecule. It's not a combination of the two. It's actually a new molecule, but it does have salicylate and omega-3 as part of it, omega-3 fatty acids. So one of the things that we wanted to look at is that the effect that's seen with Edasalonexent is not the same thing that when you give those two things together. And we did this on the right here with healthy volunteers, in which we gave them a single dose of placebo, Edasalonexent, or the same amount, essentially, of salicylate and the omega-3 fatty acid DHA. And we looked at white cells for NF-kappa B activity. We did not see a change with placebo. We did not see a change when we gave these two things together, but we did see a 70% reduction even with a single dose of Edasalonexent. So we know that we are able in adults to be able to affect that protein. So we have been working with the Imaging DMD group, University of Florida, Shriners in Oregon, and Children's Hospital in Philadelphia. They have really done landmark work on looking at MRI and its ability to follow boys over time and to understand more about the disease and be able to measure that in a very objective way. Now, the MR has a couple parts to it, and the part that we are going to be looking at first in this study is called a T2 signal. And what that does is it measures muscle inflammation, and it gives us some information about the muscle structure as well. And what they have shown, Imaging DMD, in 140 boys over 5 years, is that this increases with age and correlates, in fact, with functional measures such as the 10-meter walk, run, 4-step climb. This is objective, and in fact, they were able in their natural history study to look at what happened to MRI measures after a small group of boys started corticosteroids. Now remember, there's some overlap in the mechanism between targeting NF-kappa B with Edasalonexent and the way that steroids act. So on the right is the change in the MR signal in 3 months' time, 12 weeks, in boys aged 5 to 7, and this is the soleus muscle, the calf muscle. And they were able to see a highly statistically significant decrease in only 12 weeks. And what the reason that they found this particularly important is that if you can see changes early, that can tell us information about whether the drug is working and enable us to get to the next studies where we can look at things like 10-meter walk, run, that will enable us to go to the regulatory authorities with a fully developed drug. So they were able to see differences even in small numbers of boys, 5 boys versus 11 boys that were not started on corticosteroids. And this is really a lot of why we're working with this group and why we've designed the study the way we have. We designed it as a 2-part study. Part A is complete with 1 week of treatment of Edasalonexent. This was the first time we were looking in younger boys. So we looked at 3 doses from 33 to 100 milligrams per kilogram, dosing it on how much the boys weigh. And we looked at that for a week and then looked at that safety information as well as how much of the drug was absorbed. The second part of the study is a 12-week study that looks at 2 of the doses of Edasalonexent versus placebo. And it's very important to regulatory agencies to see the comparison for at least a short term without treatment. The boys in the placebo group will cross over to active drug after the 12 weeks and then get treated for 12 weeks with Edasalonexent. So while it's a placebo-controlled trial, everyone is exposed to drug at some point during the study. And this is the part of the study, the part B, that we're working on now. So that is intended to look at the safety of Edasalonexent in about 30 boys, so more boys than the first part, and to measure how it works and what the effect is on MRI, as well as time functional tests that are appropriate for this age group. So the 10-meter walk-run, the 4-step climb, and the time to stand. We're also looking at North Star and muscle strength, as well as PODC, a pediatric, it's a questionnaire that parents fill out. And we're enrolling boys that are aged 4 to 7 who are not yet on steroids. There's more details about that on the next slide. So we're enrolling boys that have a genetic diagnosis of Duchenne based on, and have the clinical phenotype as well, with increased serum CK, the presence of a mutation in the dystrophin gene known to be associated with a Duchenne phenotype, ages between 4 and less than 8 at the beginning of Part B, ambulatory and immunized, fully immunized with the standard immunizations of varicella and influenza. We are including boys that are not yet on corticosteroids, so we're excluding those who have been using corticosteroids in the last 6 months, or who their physicians are planning to start imminently on corticosteroids. We also do initially lab tests to look for abnormalities in kidney function or liver function that could affect the safety of the boys, and any other immunosuppressive therapy are excluded. So those are basically the inclusion and exclusion study with all genetic types and boys within the range of 4 to 7 through their 8th birthday. So we're looking at MRI as the primary endpoint of the study as a the measure of muscle damage. We have looked at that at the beginning of the 1-week study, but we'll also be looking at it at the beginning of the 12 weeks and the end of the 12 weeks. We will look at functional assessments, the 10-meter walk-run, 4-step climb and time to stand, North Star. We're not doing the 6-minute walk because the 6-minute walk isn't really an appropriate measure in boys of this age. It's more of an attention assessment. And we'll be doing these measures prior to the start of Part B, monthly, and at the end of the 12 weeks. We'll only do the MR at the beginning and the end of the 12 weeks. The MR is, many of you will not have experience with that. It is a non-invasive test. There's no sedation, there's no needles, no biopsy, no radiation. It's done at these centers that have a great deal of experience with MR in Duchenne and in young boys as well. So you can see the boy they need to lie with their leg in this MR instrument. They have set up the ability to watch video during that time. The parent is there with them. It takes about a half hour or 40 minutes. Then they give the boys a break, and then they look at the upper leg up again about a half hour or so. And the Imaging DMD group has been doing this for about 5 years and has a lot of experience. The video is clearly very important in having the boys stay still, which is important during this. The reason that we're doing this is we can look at different areas of the same muscle that can be affected, and so we're looking at not just a small biopsy, but we're able to look at all of the muscle. And what they have seen is that the same muscles that show inflammation early go on to develop fibrosis and replacement with fat. In the first part of the study, we looked at 3 doses, 33, 67, and 100 milligrams per kilogram. We did not see any serious adverse events. Everyone continued through the 7 days. And one big question for us, and I'm sure for you, is that, well, are they able to take the capsules? And the capsules are about, the bigger ones are about 2/3 the size of an M&M, and we actually made smaller ones that were about 2/3 of the size of a Tic Tac. And the boys, the first day they was a little difficult for 4-year-olds, but even after a couple days, they were able to take the capsules very well. And I think that was also because some of the parents practiced ahead of time with them. But they've been able to take the capsules 2 or 3 times a day. In terms of safety, the side effects or adverse events are shown in the bottom of the slide there. The most common thing that we saw was diarrhea in the highest dose group, 100 milligrams per kilogram. That didn't affect the boys in terms of their daily life. And they are, when the investigator chatted with the parents, they didn't feel this was going to be an issue in the longer study. We didn't see any laboratory changes in EKGs or vital signs during the study. So we decided to take the 2 higher doses, 67 and 100 milligrams per kilogram, into the next part of the study. We also looked to see how much of the drug was absorbed, because it's important. We knew from the adults how much. Is it the same in kids? And we were able to compare that with the adult exposures. We were able to show that if they took the drug with a meal with some fat in it, that allowed the drug to be absorbed well. And at the 2 higher doses, the 67 and the 100 milligrams per kilogram per day, we saw that there was a statistically significant decrease in NF-kappa B target gene expression. So the same thing we had seen in adults, we were able to see in the 2 higher doses. So that those will be going into the second part of in the second part of the study. Now, what we are also, this is a 12-week study. We are very actively planning and getting into place an extension study for this, so that the boys in all of the arms will be able to continue dosing past the 12 weeks. So this is still in process, and we are working on that to be able to allow kids to continue after that time.
And Joanne, just so as you consider this extension, and you're going up to the 100 milligrams per kilogram, are you going to continue, or have you determined what dose will be in the extension?
Yeah. So in the extension, the boys will continue on the dose that they are already on in the study, and the the boys that are receiving placebo, half of those will go onto the higher dose, and half of those will go onto the lower dose.
Great, thanks.
We have 5 sites that across the country. The University of Florida, Shriners in Portland is already active. CHOP in Philadelphia, Nemours, and UCLA. The University of Florida in Gainesville and CHOP are imminently enrolling patients. And we hope to have all 5 of the sites up in the near future. So to summarize, right now we haven't seen safety signals from the boys at the doses when given for a week. We've seen enough absorption that we are confident that we're at the levels where we saw NF-kappa B inhibition in adults. And based on the animal studies, we think that we are at the exposure levels where we saw good effects in the animal models. So we're looking now in this 12-week double-blind placebo-controlled study, the 2 higher doses. We are enrolling about 30 boys in all, and we are anticipating having the information on this study, the data, at the end of the year, and we'll be enrolling for another couple months, and we anticipate that we'll be able to have the data for at the end of the year. So what we're trying to develop is a drug that could be used in other age groups. We are also trying to work with experts to understand whether, what a trial would look like and how to get there in the non-ambulatory boys as well. And these all would be in patients that, regardless of their mutation type. Want to thank also very much the patients, the families. This is quite a lot to do. We understand that there's a burden to families to being involved in clinical trials. The patient groups, PPMD has been awesome in supporting us all the way along, and the Imaging DMD group has been working very hard on bringing this forward. PPMD provided travel funds for the first part of the study for patients and their families, and MDA is supporting the second part of the study. I have on the bottom of the slide email address to me and the clinical team. If you have questions, feel free to email, and we will get back to you on that and help put you in touch with the appropriate people at the site.
Thank you, Joanne. That was really wonderful. So if you don't mind, I'm going to go back and ask you a few initial questions, and some questions have come in. So I'm going to try to do these in a logical order, but they may fall out of sync. So in the beginning, you talked about when you've done your animal studies, and you referred to the analog. I think it was CAT-1041. And so could you please explain why you used an analog or a biochemically similar compound rather than the CAT-1004 or I know how to pronounce it, Edasalonexent, right? No, I've bungled that. I'm getting it. But could you explain why you used the analog for collecting data as opposed to the 1004?
So the difference between those, it was a very closely related analog in that it has a different omega-3 fatty acid in it. And when we were starting to look at that, we were also starting our clinical trials in adults, and that's not uncommon that we look at a slightly different molecule in animal studies than we have in the clinic to understand how it works in animals. But what we do know is that both of the molecules, Edasalonexent and CAT-1041, have very similar properties in terms of inhibiting NF-kappa B. Great,
thank you. And is FDA acceptable to the data on the analog as well?
That is information that we have shared with them.
Great. Thank you. Well, and we are thrilled that you're using MRI. This is something that's really important to us because we as a community really hate the idea of biopsies, and certainly the idea of seeing an early signal based on a compound would be amazing. So I'm happy that you're looking for an early signal on MRI. And so I wondered, as you think about these studies, what is your regulatory strategy after this phase, after the placebo-controlled study and dose finding? What do you expect you'll do a full-blown phase 3, or do you think that you might, cross your fingers here, have sufficient capability to go to the FDA for an accelerated approval based on what you find here?
Yeah, that's a great question, and obviously a great concern to parents. I think that what we are trying to get out of this study is an understanding of the MR effects. We think that it may take longer than 3 months to see the full effect, and that's one of the reasons why including boys in an extension study is also important to see the effects and the safety. So our intention is, though, to be able to see the effect on MR in a relatively small group of boys, and then initiate a phase 3 study next year to be able to support registration.
Right. So the idea is you might see an early signal on the MR that may not translate into functional benefit or preservation, but that would require the longer-term study.
Yes.
Okay. Thank you. And we're really thrilled that you're thinking about the non-ambulatory group. And I think one of the frustrations in the community is in a non-ambulatory study, often it is individuals who have lost the ability to walk or lost the ability to complete a 6-minute walk test or whatever criteria up to and including maybe age 16 or 18. I think one of the worries of our community, and certainly as we think of the young adults, especially the potential of benefit to the respiratory apparatus, this would be an amazing opportunity for the adults with Duchenne. And I didn't know if you all had some internal discussions about thinking about how to treat adults, and then I'm thinking in the longer term about your labeling, because we'd certainly want a broad label so that everyone who had the diagnosis of Duchenne could take advantage of such a drug if it's approved.
Those are all very important things to think about, Pat. I think that one of the great ways that PPMD has supported us and other companies that are developing in the area is doing things like the pulmonary workshop a couple months ago, where with their 2-day workshop focused on the pulmonary endpoints. And I think that really helped us a great deal in thinking about including boys and young men in the study and how to design those studies in a way that is as inclusive as possible, that includes patients on the basis of where they are functionally, as opposed to potentially to perhaps a strict age cutoff. So that is something that we are thinking about and talking with experts as we move towards to starting a study up in that population.
Thanks, Joanne. And for those of you on the phone, several weeks back, PPMD held a workshop to look at pulmonary outcome measures in Duchenne. We had probably about 50 experts around the table and many companies who include the CAT basis group to really sort through what are the best measures, how to measure them rigorously and consistently across. So that's what Joanne referred to, and I think this is really important because I can't imagine being 19 years old and having the potential and maybe not being able to reach it. It seems we have to do something about that, and quickly. A question has come in, Joanne, about you mentioned the NF-kappa B pathway, and you mentioned that, in fact, this pathology, this sort of pathological cascade, really limits the ability to regenerate of muscle. And so have you seen a specific effect on muscle stem cells in the mouse studies or any of the animal studies you've done?
We haven't done exactly those studies. We are doing more studies preclinically to understand that effect, and as we do those and we get that information, we'll certainly share it publicly.
Great. Thank you so very much. And I think there's questions around the long term. With steroids, steroids certainly suppress the inflammatory response through the NF-kappa B pathway for a very long time, and these individuals with Duchenne are on steroids sometimes for 10 or 20 or 30 years, and we certainly see significant effects over time that seem compounded. So I think one of the questions that has come in is, are you worried about the long-term effects of the CAT-1004?
That's a great question. What we have not seen in the studies, and one of the things that we do to support studies in patients is to look at it in longer term in animal studies, and we haven't seen evidence of a decrease in the immune response or in inflammation. that has a negative effect, for example, in fighting infection or something like that. So that's something that we look at and we have not observed.
Well, it could be true, right? That you're decreasing the NF-kappa B pathway. You're not wiping it out, so you're significantly impacting it, but not completely removing that pathway. Or
one of I showed that there is animal data in the MDX animals. If you knock out half of the protein, basically decrease it by 50%, and those animals are normal in phenotype. They don't have any negative effects on their with infections or anything like that. So that's a very important point, that we're not wiping it out, we're decreasing it, and we think we're decreasing it to a level that, based on the animal studies, we think could be very important clinically.
Right, so you wouldn't be worried about a lifetime of taking this medication at this moment with the data that you currently have.
We'll continue, and we also will continue the longer range studies in animals to support that. But we don't have any concerns about the infections that have been identified at this point.
Thank you. And I think we all on the phone probably are well aware, some probably personally on the phone, of the impact on bone health. Have you done any studies? Are you aware, or do you have any sense of the impact or not of CAT-1004 on bone health?
Yeah. Again, we don't expect that Edasalonexent will have negative effects like steroids on bone. And as again, not planned in advance, Pat, but great workshop a month ago also on bone health. And I think that it's clear, and we all need, as in doing studies in this, to capture all of the information we can about that. NF-kappa B is important in bone health, and and higher levels of it, activation of it, inflammation, has a negative effect on bone health as well. So that is something we don't have any data at this point, but it is potentially a good thing to inhibit NF-kappa B in chronic inflammatory states.
Right. So in the bone health meeting, there was some discussion and around the value of the Z-score as opposed to doing spine X-rays, and in general, it was discussed that spine X-rays are a much better indicator of bone health than the Z-score itself. So I think making sure or trying to understand what if there's less impact, and I am suspecting and hope that CAT-1004 would have less impact on bone or no impact on bone, which would be ideal for all of us. I think, Joanne, you've answered all of our questions. One final question from me might be, some of these sites are already recruiting, and I feel quite convinced that there are lots of people who are being diagnosed that are quite interested in the study. So we would love for you all to update us about your successful recruiting, and very anxious to hear from you at the end of the year. So if recruitment is on target and if you get the data, you'll come back to us and tell us what you've learned very shortly thereafter?
Absolutely.
That would be wonderful. Well, I can't thank you enough for this. We're all very excited about the opportunity of a steroid replacement drug or something that would really decrease the need for steroids even to 0 or less than the current dose recommended. So thank you very much, and we will see you very soon at the conference. And for all of you who joined us, should you have more questions, please let us know, and we're always very thankful that you've joined us on these webinars. Thanks again.